Initially, only bureaucrats went. No academicians were part of the delegation. So maybe this is one of the tasks for the Australian policymakers. When they send a delegation for negotiation, they should take a Australian academician, global health academician as part of the delegation. That's one. But second, maybe they should have separate slot on the students, global health students to be part of the delegation. The US normally send about 50 people. This time 0. And that was a significant implication. Most of the discussions, no discussion, okay, done. Each word is being debated. Each word is being discussed about it. Then the global health policy, the wordings, the use of language sometimes. All this is very fascinating scenarios happening. And new players coming in the global health.
Okay. Are we ready? Yeah. Okay. So thank you everyone for coming to today's special session, and thank you very much for joining online. As you probably have seen from the announcement, today we have a guest speaker, Professor Joe Thomas, who's going to share a little bit of his experience in global policy and the global context. And he's going to talk about his work in the World Health Organization Assembly, his experience in the World Health Organization Assembly. So please allow me to introduce you to our guest, Dr. Joe.
Good afternoon, everybody. And thank you for being here. And also particular thanks to Roberto. And also I must say thank you to Dr. Fayaz. Yeah, he is instrumental for me being here. And what I want to talk today is about the World Health Assembly of WHO. What is the World Health Assembly and why it's important? And I'll be presenting 5 takeaways from the World Health Assembly and some of the concluding observations. So this is what I'm going to talk to you about. Approximately, I have 20 slides. So normally they say that you take 1 or 2 minutes per slide, so you can calculate. So I'll not bore you more than half an hour. If you have any exciting or difference of opinion, I'll be happy to take it, and I'll be happy to spend more time. And Roberto told me that the afternoon is for yourself. I know that that may not be the case for most of you. So the World Health Assembly is the general body of the World Health Organization. At the World Health Organization, we have 194 countries. And this number is important. There are 94 countries for the WHO, only 192 countries for the United Nations. So in terms of the participation, there are more people at the World Health Assembly, And the World Health Assembly is assembly of in the practical sense, the ministers of the health. So if you want to see 194 health ministers go to Geneva and attend the World Health Assembly. And who are the participants in the World Health Assembly? We have many global health conferences. Recently, there is a global health conference in Victoria, and there are many global health conferences. But the World Health Assembly is different in many ways. One is that's a meeting of ministers, senior officials, and also the part of the decision making related with health. So that makes more important that. So in that point of view, the World Health Assembly is the primary global health policy setting institution or agency of space. And also that's an international venue for collaboration, partnership, participation, exchange of formal and informal partnership. That's the second part of it. And also there are new initiatives are being promoted and also implemented, evaluated, contested. So this is another part of the function of the World Health Assembly. And also resource allocation. And the World Health Assembly decides what programs, how much they should allocate for that. And that decision normally reflect on other donor agencies also. And that is reflect on other international governments who is supporting overseas aid. So the global resource allocation has got a gatekeeping capacity by the World Health Assembly. So because of that, you should keep a very close eye on what discussions take place in terms of resource allocation and monitoring and accountability. You monitor global programs. There are many global programs. For example, Partnership with Maternal and Child Health, one of them global program. So they monitor what is going on each area, particularly on this program. How much money is going for maternal and child health program on global level on each government, and also they seek accountability in terms of they ask for commitment from each country. They ask each country to make explicit commitment for each program, and then they'll hold them accountable. So this is another major function of the World Health Assembly. And also this is about the governance of global health, how the global health issues are being governed and global health itself is governed. And most importantly, how the World Health Assembly is governed. World Health Organization being governed. That governance means including the selection of the senior official, Director General of WHO. So this is why I mentioned this important because the next year is election year. So this also has got very implication on that. Who will be elected, the process of election is all part of the this year, this World Health Assembly, one of the informal discussion was about who could be the next DG. Informally, there's many discussions took place, who should be elected, what's the process of election. There's a very systematic, well laid out program for election, but it's a political decision. Political decision by 194 Ministry of Health. So that makes the complexity. Sorry. Okay, sorry. Right. Yes, go ahead. And this year, and this World Health Assembly is approximately 9 days meeting. You can imagine 9 days Jamboree in Geneva. And there are 72 items in the agenda for these 9 days. And this year is one of the shortest agenda items. Last year, it was 182 agenda items. Normally, 150 to 180 items are discussed at the World Health Assembly. And this year, 72 items, then 300 side events. And side events could be at the press club, at the corridor of the Intercontinental Hotel, Presidential Hotel. So this side events are very strategic meetings. This can be sponsored by WHO. It may not be endorsed by WHO. Sometimes it is in contradiction to WHO's main position. So these 300 sessions are spread out all over the place, whereas the main session takes place at the Palais, at the main UN body, UN building. And also, when I mentioned about 75 items, I'll explain some of these issues. And I should give a one, caveat. 72 items, you may not be able to go through each and every item. So I picked and choose some and I presented here. It may be a selection bias. So some of the issues I may have left out. So I leave it with you to find out what is my bias, or maybe I'll explain it how I selected it. And if you look at this year 78th World Health Assembly, one is the resolution highlighting pandemic treaty. I know many of you are aware of the global community for the last 3 years discussed and negotiated, argued about a global pandemic treaty. Pandemic treaty is about, pandemic treaty is expected outcome, but pandemic agreement. So right now they have a pandemic agreement. There's a huge difference from policy point of view, a global pandemic agreement and a global pandemic treaty. If you're interested, I can elaborate on that, but this you should remember that what they sanctioned is a global pandemic agreement, not a treaty yet. So this is one aspect of it. And also, this meeting, the Global Health Assembly looked at the global health financing emergency. They highlighted it. Then one of the first resolution on lung and kidney health, and there is a UN General Assembly is coming in July, August. So UN General Assembly is going to take about 6 global health issues, and the World Health Assembly endorsed the themes for that UN General Assembly in New York. So these are the 2 areas where global health issues are discussed. If you want to unpack this little more, this is one area of global health diplomacy is being practiced. Those who are interested in the global health, one of the important aspects of global health is global health diplomacy, how global health is negotiated politically at the different forums. And increasingly, global health is being discussed at the UN General Assembly. That is, as the word mentioned, states, it's a General Assembly, not necessarily Health Assembly. But the General Assembly is increasingly taking health issues as a major component. And this shift is important to understand from a global health point of view. Global health is going beyond WHO. This is mostly because of our understanding about social and political determinants of health. Those who are looking at the social determinants of health, there are social and economic consequences and determinants of health. So that transition and health in all policies, another concept. These are the 2-3 ideas which is driving global health and why it is pushed to the new UN General Assembly and also UN Security Council. Health is increasingly being securitized. That has got benefit as well as risk involved in that. The first time a health issue is being taken at the UN Security Council as UN HIV/AIDS, because UN peacekeepers are getting infected. Then they thought the capacity of the UN peacekeeping effort is being compromised because of HIV infection. So that is a route in which UN Security Council thought, and we had to look at the health issue as part of a security issue. So health is being securitized, but that has got a major criticism. What is the benefit of securitizing? What is the risk of securitizing? Because we know that health is understood as a basic, essential human right. A right-based approach and a security-based approach has contradiction. So that, anyway, that is not part of my today's session. I'm just highlighting it to let you know that. And also there are other resolutions looking at, there are norms and standards of health policy and how health policy should be developed and how health policy should be implemented. This is one of the major resolutions came from the 78th Global Health Assembly. If you're looking at the health policy, I would suggest that look at that resolution very carefully, how to create policy and how to implement policy as one thing. And also the target, they set a new target to reduce the health impact of air pollution by 2040. This 2040 is also interesting because 2030 is the deadline for Sustainable Development Goal. So they very quietly pushed the boundary for 10 more years. This also got implication. I'll come to that, shifting this 2030 to 2040 because SDG is supposed to be met by Sustainable Development Goal has to be met by 2030. And in Sustainable Development Goal, there are about 50 goals related with health. And approximately 50 targets will not be met by 2030. So there is something called unfinished global health agenda is brewing up. But the question is how are you going to deal with unfinished agenda? And anyway, I'm just jumping the gun. And that should have been one of the major opportunities for Global Health Assembly, which they hadn't looked at it. Also, this has got resource implication. The resource implication number one is that none of the countries is costed. What is the cost of implementing Sustainable Development Goal? What is the cost of implementing the health-related Sustainable Development Goal? So unless you do costing, you know that it is not going to happen. Unless you allocate resources, it's not going to happen. This is a basic understanding about health policy. If the health policy is not costed, health policy is not budget allocated, then health policy is just on the paper. So this is when you look at from globally, these are some of the implications. I'll come to that. And again, I'm just listing some of that. I mentioned that I picked and chose, and some I left out, not deliberately, but some I deliberately did. And one of the important resolution came social connection between social connection as an important relationship in terms of the health outcome. The health outcome is impacted, influenced by social connection. Or the density of social connection is going to influence your quality of life and well-being. This is one important understanding about global health. And what is the meaning of social connection? And how do you measure social connection? And how do you invest in social connection? As the governments how do you allocate public health money for promoting social connection? So these are some of the important part of it. And those who are focusing on the social determinants of health, this is one of the latest understanding about what are the determinants of health, that social connection, which this didn't receive much attention. But let me just pause here. Those who are in the research field, you're familiar with you do a situation analysis, or you do a review of literature, systematic review of literature, bibliometric analysis. There are many ways of looking at what is the body of evidence, body of knowledge out there. But that the UN General Assembly, in the World Health Assembly, the ideas are promoted not exactly through a systematic review of analysis. This is an interesting decision making, but it is done through many opinion makers. So the opinion makers' evidence is considered as the best evidence in global health is clinical trial evidence. That's the first thing. Then there's a hierarchy of evidence. And the hierarchy of evidence, public opinion or expert opinion or Delphi approach is considered as somewhere in the middle. So the WHO, when they push for agenda, one of the agenda is to what extent it is peer reviewed and what extent it is systematically reviewed. This also, those who are interested in taking this forward, and just leave it as a kind of certain flag. You can take it or leave it, but these are some of the very interesting observation I'm sharing with you there. And the other important resolution was the code of marketing of breast milk substitute to tackle digital marketing and formula milk and baby foods. And when you look at the baby food, the sugar content in the baby food and the multi-processed baby food. So these are the two contents. And if you look at Australia, if you look at the baby food sold in Australia, very interesting part of it, the sugar content is not clearly mentioned. And then compared with other OECD countries, the baby food sold in Australia, the sugar content is 6 to 7%. Whereas in other OECD countries, sugar percent is 0. And the standard understanding is that the neonatal food supplement should have a 0 added sugar. The sugar should come only through the fruits or other non-added sugar content. I'm just giving an example about it. So Australia was an opportunity to revise Australians' marketing standards in promoting baby food. So I'm just giving again and flagging one of the ideas which came through the World Health Assembly. And also there are guinea worms eradication resolution. And also there is a formal discussion about the digital health, how the digital health to be formed. And in that, there is an underlining factors about internet health and even ethics of internet. What are the ethical parameters for involving, utilizing internet? These are some of the subtext between the lines in that resolution. And resolution on health and healthcare workforce. There is a global review of the healthcare workforce. And interestingly, there is about 40% there will be a gap in human resources for human resources for healthcare globally, and particularly in the developed countries. But we assume that this will be supplemented by people trained in the developing countries. So this is one of there are detailed breakdown of the country-wise breakdown, what is the resource requirement, what areas is the requirement, all part of this global review of human resources required for global health. So this may be an interesting area. You had look at it, your future job opportunities to scout for it. It may give some idea about it. And also resolution on sensory impairment. That's a part of the diagnostic support, and also it's a part of the assistive technology. They mentioned about almost 25 assistive technologies are being in the market, and access to assistive technologies, how it's going to improve health and well-being. This is also an important part of the global health. How do you access assistive technologies? And the research, diagnostic for assistive technology, and also access is a major issue. And also innovation in the area of assistive technology. These are some of the take-home messages you can say then. There's a resolution on skin disease. And there are two global health campaigns was implemented there. One is about World Cervical Cancer Elimination and Day of World Premature Day. Premature birth is, there's a global campaign to reduce this. These are the two global campaign initiated at this assembly. And but the most important thing was the pandemic treaty and the pandemic treaty and pandemic agreement. I put agreement because a global agreement to becoming a treaty, there is a long way. There are many stages it has to go. The agreement may be done by WHO, but the treaty is signed at the UN General Assembly in New York. So this is the one major part of it. The treaty is signed always by the head of the state or deputy head of the state or the head of the foreign minister at the UN General Assembly. So, and the treaty has to be approved by member countries who signed it, and their parliament has to approve it. So that's the stage of an agreement becoming a treaty. So even though WHO agreed on a treaty, this treaty has got very interesting history. Number one, this treaty was negotiated by a treaty negotiation body created by WHO. It took 3 years. But at some point of time, so observing this process, we thought it's not going to happen at the 78th World Health Assembly. But interestingly, they reached into consensus. This is an interesting case study about how you reach consensus about global health policies. What they did, all the areas they can agree, they put it in the main text. And the areas of disagreement, they put it in the appendix. And the areas of disagreement, they put it in the appendix. And then they said, let's agree on the main text. And the appendix we negotiated further. So if you look at the process of selecting, agreeing on certain issues which you cannot serious disagreement, how do you do? You agree on only areas where you agree, and other areas you postpone it. So this is what happened. So what they call it as Appendix 3.2, there is a serious list of disagreement. They put it as further negotiation, but the main text is approved. This is very unusual in the global decision-making body. But from a decision-making process analysis point of view, very interesting, interesting phenomenon, interesting case study. You agree on what you can agree. You cannot disagree, just keep it aside. We'll deal with it later on. That pragmatism is interesting to observe as a global health student. You should, because there are other global negotiations going on. There is a plastic treaty is going on, elimination of plastic, reuse of plastic. There is a global negotiation going on. 3 years, they never reached anywhere. And also there is an ocean resource sharing pandemic. The treaty is going on, Global Ocean Treaty. That treaty is also didn't reach anywhere conclusively. So this, and also there are carbon reduction treaties going on. There are many other global treaties. There are what they call it as the partners of agreements. There are different opinions, but they couldn't reach anywhere, so they didn't agree at all. But when it came to WHO, they agreed only what they can agree. So this is one interesting case study you keep in mind, that how do you solve some of the global problems at the global scenario level. And also this is the second international agreement or treaty after the tobacco treaty. Tobacco treaty is considered one of the success of WHO, reducing the use of tobacco on a global level and reducing the advertisement of tobacco. And overall reduction in tobacco use is mostly because of the tobacco treaty. And there's another interesting number is there. This agreement was the adoption of this statement was put it for voting. There are 124 in favor. There are 0 objection. 11 countries abstained. So this is the voting pattern. But this number, does it make any sense for you, anybody? Anything interesting about this number? I was trying to figure out some mystery behind this number, because remember 194 member countries are there. Only 124 voted for it. And what happened to almost 70 countries? There's no mention. I tried to look at the voting pattern, voting number, and I tried to scroll to find out what happened to 70 countries who didn't open for it. Even these 11 countries, who are the people abstained? That I managed to get a list of it except one. That data is also not in the public. I look at the ChatGPT, Pilot, everybody, and Google Scholar, everybody. And also I looked at the original the voting pattern. But this almost 70 countries presents what is the position about global pandemic treaties is a mystery. This has got significant implication, because when the next level of negotiation comes, they may group together. And now let's look at this. Who are I'll come to that. Which countries abstained from voting? US was no, I mean, they didn't show up. They no show of one country. Poland, Israel, Italy, Russia, Slovakia, Argentina, Iran, and New Zealand. And the New Zealand is interesting part of it, stand out from all this usual crowd. Because normally other countries, they take their position very clear. They take their sovereignty as an important part of it. And all these countries, the main reason for non-agreement with the global treaty was saying that this treaty is going to undermine the national security, national sovereignty. So this, in Australia also, there's a strong movement against Australia being part of this pandemic treaty. Very strong social movement took place on our internet and social media. Very actively they promoted against why Australia should not be part of this pandemic treaty. But anyway, the official government position was that we are supporting it. And New Zealand is interesting part of it. The previous New Zealand Prime Minister, she was part of this initial body, and they endorsed very clearly. But when the political scenario changed, they backed off. So this is another important issue. Many countries, even though they endorsed it, they may back off if there is a political scenario, domestic political scenario changes. So that way, pandemic treaty, as it is now, it is just what I would say. I mean, I'm sorry to be a bit cynical. It's a wish list. Even though there are 124 countries agreed to that, but even at the UN level, when it's becoming a treaty by signed everybody, the implementation is based on each country's internal political scenario. So this is, I mean, there are many specific issues. I'll take a few of the issues under. And the main text is about principles, approaches, and tools for better international coordination across a range of issues. So this is the main text of it. And also, this agreement is to strengthen the global health architecture about prevention, preparedness, and response. These are the major areas. And equitable and timely access to vaccine, therapeutic, and diagnostic. This original text has got 33 pages, 3 chapters, and 35 articles. I tried to look at the word count, but I didn't manage to get the exact word count because it's a PDF version. And this text is this 33 pages, but I was following up the different version. I mean, it's about 6-7 versions came. So I had access to all the versions, the initial one. One of the major contentions is about health equity in the global level. How do you implement health equity at the global level? How health equity on a policy level, how do you implement it? And on a practical level, what are the health equity? Vaccine access, that's one of the health equity issue. Diagnostic access is a second issue. And also the treatment and medicine access is the fourth part of it. So access to these are the important part of it. When the COVID vaccine came, and the COVID vaccine even created a new word in epidemiology called vaccine nationalism. And many countries, they hoarded, they just bought up the vaccine. They didn't even distribute, and when it became expiry date, just literally threw out $1 million worth of vaccine. So this is one major issue about how do you ensure if there is a new pandemic or new disease comes up, how do you ensure that vaccines and vaccines and diagnostics are immediately accessible? So this is one of the major bone of contention in the pandemic treaty. And this appendix, one of the issues about what WHO proposed is that 20% of all the new discovery should be accessible to everybody, that WHO will manage. But then the issue came, who is going to finance the discovery research, and also the issues of new medicine, clinical trial, all this, who is going to finance it? This issue came up. But at the same time, this is a way, how do you translate global health equity on a policy level at the international level? And this will remain as one of the major, I mean, if anybody is interested in a PhD thesis, how do you translate global health equity on a policy level at the global level? What are the mechanisms? What are the modalities? What protocol should be in place? What are the barriers? So this could be one of the major area of interest, which we have to look at it. And that way, very interesting to see that how this the appendix or the pandemic treaty may be negotiated for the next year, what modalities they come out with. One of the model they proposed is that WHO will manage this 20% of all the discoveries. But what is the developing countries, what they say is that what they have in their hand. They have the pandemic viral module, what do you call it, the viral mechanism, the DNA, the original DNA is with many of the developing countries. When the COVID came, the original virus DNA was only with China, because no other country had that kind of, what do you call it, the subtypes of the virus. And unless you have access to the original DNA of the virus, you cannot think about vaccine. So they said, and also Indonesia had the virus subtype, they had capacity to extract it. But at the same time, they put up a condition: we'll give you the DNA, but you should make sure that the vaccine should be shared with us as well. So this is going to continue in the future also. The viral DNA may be sitting with one other poor developing country, but the capacity to manufacture, create, discover, innovate a virus or a vaccine or a diagnostic facility, maybe with a developed country, a huge pharmaceutical countries. But who will negotiate this? So this is another area, because the global health scenario is changing. Some of the global dominant players are they resigned and they left. So WHO's capacity to negotiate through this pandemic treaty is important. So as a global health student, maybe this is one very interesting scenario how this is going to come out. And again, I told you that there are 33 pages. There are Article 12 about this is called Pathogen Access and Benefit Sharing Scheme, PABS system. This is what is in the appendix to be negotiated. And what it says that the pathogens and pandemic potential, the material and the sequence information, modalities, legal nature, and all this should be equitably distributed. That equitable distribution may be managed, supervised by WHO. So this is one of the WHO's function. And also PABS instrument is defined the terms of administration and coordination by WHO. There are 6 specific terms and conditions, but this is not agreed at all. So how do you ensure this equitable access? How do you negotiate this distribution? And how do you manage it? So this is what is going to be discussed in the appendix part of it, PABS access. And also, there are other different international donors involved, then the stakeholders involved. Then again, another major bone of contention is that the PABS negotiation, whether pharmaceutical companies, international pharmaceutical companies, that they should be part of this negotiation at all. So this is one of the major serious disagreement, because WHO, they have something called a very clear definition of who can be part of the decision making. Because the WHO and World Health Assembly, the participants are the Ministry of Health and what they call it as the non-state actors with official relationship with the WHO. There are many agencies, they get an accreditation to WHO through vetting process. And also all the participants at the WHO World Health Assembly, they had to sign a no conflict of interest resolution, a statement they had to sign. At the same time, a pharmaceutical company directly being part of the negotiation, it may violate this neutrality issue. But then many of the leading pharmaceutical companies say that unless we have access to the information, we may not be able to discover a new vaccine. So this is who is going to manage it. How do you reduce the influence of larger pharmaceutical companies in deciding and setting the agenda? Because this has got another historical understanding. Many of the pharmaceutical companies, they are reluctant to invest in money for tropical diseases. But whereas they're willing to invest money on cancer, some of the diseases which are more prevalent in the developed countries. But the investment quite often goes to the developed countries' health needs, not necessarily the health needs of developing countries. But in the health point of view, health is everybody's business. If an unhealthy person is anywhere in the world, that can potentially become an issue for everybody. With COVID, but that's what you notice that COVID may began from one of the remote area of some marketplace. Within few weeks, it became a global pandemic. Imagine Melbourne was closed down for 2 years. Will it happen again? I mean, theoretically, there's a potential, but politically, will it happen? So these are some of the issues on what ground they will do. And also, we know that many governments, they came out with their own laws to control and to reduce the social freedoms and the delicate balance between the civil rights and the epidemiological requirement. How do you balance it? This is another challenge is going to come. And most of the countries, particularly the 11 countries, they specifically said the major disagreement is about national sovereignty. They say our country should have national sovereignty. We are not willing to undermine that. But if you look at the pandemic treaty, the text, it very clearly said the entire final ultimate decision about any health related issues are by the national governments. Whereas New Zealand insisted that we'll subject this treaty for a national interest test. And what is this national interest test? We don't know. But they explicitly said this is going to violate the sovereignty of New Zealand. But you know that most of the New Zealanders can come into Australia. Australia is a part of it. So these are some of the delicate health diplomacy issues. I'm just dragging you to another area of global health. And another important part is health diplomacy. How do you negotiate and getting things done at a political level? And also, how do you negotiate for the better outcome of your national governments? So these are the issues which what we broadly call it as a health diplomacy. And those who are specializing in global health, an evolving area is global health diplomacy, and Australia is playing a very active role in global health diplomacy. And I don't know how many of you know that Australia got a global health diplomat, a nominated, designated global health diplomat. So maybe you should take a look at it. What is his action? And it's happened to be he. So how he is negotiating for Australia, how he is going to negotiate. And also, maybe that is an opportunity for many of the students who are looking at global health. What is your international opportunities? Because he is sitting with $300 million to throw it around, mostly in Pacific areas, and also specific programs. These are the programs in which some of you are going to work in the future within 2-3 years. So because of that, look at Australia's global health diplomacy efforts. Who is doing it? Who is regulating it? Where they're going to invest money? What is the exact mechanism for that? And again, as I mentioned earlier, the pandemic agreement is still an unfinished agenda. Number one, the agreement, the appendix has to be negotiated and done. And also, we hope the 79th World Health Assembly may be discussing in the final text. That is again next year, May, June, during that time. And also, what are the disagreements? Let me just look at the disagreement, because I told you that there are 72 countries' position is not very clear. But most of the countries, there is a common discussion. The discourse is that WHO is going to undermine the sovereignty of the country. That is one of the major bone of contention. The Polish delegate, they explained detail, number wise. They said it's going to compromise their national sovereignty. Russia also same, the sovereignty concern they raised. And Iran, they explained it. They also went a little ahead. They're saying that the developing countries' concerns and issues are not addressed at the pandemic treaty. So Iran put a position that they took on behalf of all the developing countries. But in my point of view, the point they raise is not valid. Because if you look at the text, the 36 page, if you look at clearly, there is nowhere it is mentioned that it is going to undermine any of the national decision-making body. And also New Zealand said they subject the treaty to a national interest analysis. It may be very interesting to see that the tool they're going to develop to look at what is the national interest analysis for a global health point of view. Maybe what are the opportunities lost analysis tool, maybe we have to create one. By not being part of the treaty, what are the opportunities lost? And this has got implication in Australia, because New Zealand health burden is a health burden for Australia as well, because of free exchange of people between two countries. So this Australian position about global pandemic treaty is a major concern for the public health community in Australia as well. There's a need for discussing, debating about it. I'm not getting into the detail, I'm just flagging that's an issue, because it's going to be a very politically volatile subject. But remember, global health is about politics, and health is about politics. So we cannot avoid not discussing about it, but taking a position is a policymaker's decision. But being a part of it, being analyzing it, being understanding, being an explanation about the scenario is a responsibility of global health academic community, particularly if you want to take up a research, please take an opportunity to look at this issue. Then there is a say in the elephant in the room. And also, I never heard that the elephant is not in the room, elephant escaped from the room. In the US was never, for the last 70 years, United States was part of the major global health decision-making process. And also, if you look at globally, United States is the leader of global health on various ways. One is the finance investment and also human resources. In WHO, there are about 300 people in United States seconded working in global health issues. This is one part of it. And the second part of it is that USAID is being dismantled. And that is one of the major significant impact on global health all over the world, including Australia. And I'll come to that. This needs a little more elaboration. And normally, I've seen for the last 6-7 years, I regularly attended. US, they send a delegation of about 50 people. And the delegation members are normally senior faculty members, professors of, you name it, all the schools of public health from all over United States. They come for the negotiation and they put their foot down. They negotiate each and every word and all the resolutions. So I can generally make a statement saying that earlier, all the global health policy decisions are approved or disapproved with the stamp of United States point of view and their worldview about health. So this is one of the scenario. This is the first time there's no US involvement. So most of the discussions are being discussed by other delegates. There is no serious disagreement. There is no serious challenge. And also it is mostly, but then what I looked at is that the quality of discussion didn't go beyond a bureaucratic discussion. This is one of the qualitative discussion because even though very imposing professors on global health comes and sit there, negotiate, they do their homework. They really take it apart. In one way, that's a good thing, but there's also got other drawbacks. But this time, the US influence was not there at all. But the important implication is that the global consensus is weakened because United States completely unanimously gone out of the global health agenda setting, including the pandemic treaty, including the exchange of ideas. This has got many interesting things. I'll come to that. And when you look at it, the most important implication of US withdrawal is US closed down the USAID. That's literally almost overnight. They sent a notice for about 6,000-7,000 staff saying that don't come to the office from tomorrow onwards, and they locked out their biometrics, they couldn't access it. So, and if you look at the resource wide, $8.5 billion is withdrawn from overseas aid. Out of that, 2.5 billion is for the global health. Overnight, global health lost $2.5 billion. And then new players are coming, they diminish US leadership. And this has got one important implication is that United States is hosting, there are 72 WHO collaborative centers. So probably this has to be, there should be a transition, removing from United States other countries. Maybe Australia can bid for a few WHO collaborative centers here. I mean, I'm not joking about it, it's a serious issue because this has to be dismantled from United States because if the US is not coming back to WHO as a member state, logically, it has to be logistically also you have to remove it. And the CDC itself is holding 11 WHO collaborative centers looking at very critical issues. Unless this is systematically removed and transition is ensured, there are many serious disturbances about the data because global data is negotiated, managed by WHO collaborative centers. Australia also got about 40 collaborative centers. Maybe this is an opportunity to take a relook at WHO collaborative centers in Australia, how they work, and what is their contribution towards global health. These are the side event issues, but at also same time, this gives an opportunity to look at it. And again, the impact of USAID, there are 176,000 additional adult and children around the world could die because of HIV. But HIV treatment is largely supported by USAID and President's funding for HIV/AIDS. This was a $15 billion for the long multi-year funding that's cut. And also 62,000 additional people die because of tuberculosis, because tuberculosis medicine is withdrawn. Oxfam America is saying that 23 million children will lose access to education. But the most important from a public health point of view, many of the clinical trials were closed down almost overnight. This has got serious ethical implications because when you withdraw arbitrarily, abruptly from a clinical trial, it has got implication. Both trial arms has got implication. How do you compensate them? How do you continue the clinical trial implication? How do you monitor it? There's no resources, there's no people. So closing down several thousand research projects has got serious implication on global health. And also already there are 15,000 children and people, including 1,500 children, already died because of the cuts. So these are the very human resource implication and the implication on health and well-being. And there are a few other interesting scenarios I heard from Geneva. Geneva is a small city. It's half of Melbourne. It's maybe a little bigger than the CBD, if you look at that way. And Geneva is going to have 8,000 vacancies for the houses, because 8,000 people are going to leave from Geneva because of the job cut. And just give very specific, immediate impact of that. And WHO already the senior reshuffling happened. There are senior 8 ADG level, Assistant Director General level, they lost their job. Now they're going to cut down. There is one D1, D2, that's a senior level there. And out of that, I mentioned that about 300 plus US delegates, they're going to leave overnight. So this whole transition being worked out. So WHO's overall staff strength is about 8,000 people in Geneva. And not only WHO, there are Global Fund, Gavi, there are many other health-related global institutions. They're going to cut down their staff, or they're going to reallocate their function from Geneva to other countries, other developing countries or developed countries. So there is a huge restructuring is taking place, global health on a huge specific impact level. And where there is interesting thing is that just outside WHO, the main building, there is international school is there. And the school may be closed down because the children in that school is from the WHO staff, and they're going to withdraw the children, they're going to get out of Geneva. The school is going to close down. Imagine a country like Switzerland is going to have a serious financial implication in the context of global health. And some people jokingly said this is actually a war against New Zealand. It's Geneva or Switzerland, financial war. Now, some of the closing remarks. What is implication on students like you or those who are in the global health? Number one, the opportunities of global health is going to reduce. At the same time, new opportunities are coming up. New players are coming up. So for that, you have to have a reassignment or realignment of your own education system to see that what new opportunities are coming up. For example, global health diplomacy. And who are the new players? I looked at, the SAARC countries, the BRICS countries, they had a slightly higher involvement. South African minister was negotiating chief, South Africa. Some of the developing countries, they're taking new position on that. And China sent a delegation of 120 delegates. It's the first time I've seen that such a large delegation came from China. And they were very active in participating in all the session. But what I noticed is that most of them were young students from some of the prominent school of public health in China. So that's the interesting part of it. There is a new batch is coming up. But Australia, about very small delegation, about 14 of them, but nobody from the academics or a student version. So in future, probably the academic community in Australia in public health, global health, they should ask for a seat in the Australian delegation in any of the global health negotiation as a learning exercise. But this also should reflect on Australian global health or public health education syllabus need to be looked into what is opportunities. Because global health is normally understood in the umbrella of United States policy making opportunities by the US agencies. And how other countries' agencies are coming, how do you engage with them? And also clinical trials being, how do you renegotiate for financing and implementing it? And how do you utilize this power vacuum? And Australia got a great opportunity, but you should have a national agenda, Australian national agenda for global health. Probably this has to be negotiated and discussed under the leadership of global health academicians and the students. And most probably, my fear is that the opportunity for global health advocacy, the thematic issues of advocacy may be reduced. And global health is about promoting, working towards global health equity. How far we may be able to promote and work for it, that will remain as a great challenge. Thank you very much.
Thank you very much.
Yes.
Thank you very much, Dr. Joe, for this wonderful presentation on the global health diplomacy context, particularly with these big changes that we're looking, and as you say, the shift that is happening in the international political context. So before moving on with any other discussion, is there any question for Dr. Joe? See, please. Or any comments that you have?
I did have a question. Now I can't remember what it was. Thank you so much for an excellent presentation. It's quite an eye-opener. I think it was when you had slide number 5 up. I had a question and I can't remember what it was now.
Just let me go to the slide. I can share again the slide so you look. It was this about the World Health Assembly?
No, it wasn't that one. Maybe number 6. Yeah, so I think the question that I had was that who represents each country at the World Health Organization Summit? Is it the health minister or is it an appointed public health CEO, or who actually represents the country at the summit?
Thank you. Thank you for that question. The World Health Assembly is an assembly of the health ministry. And normally health ministry is leading the delegation. And at the assembly level, at the assembly, the body, only 4 delegates can sit. 2 in the front, 2 just behind that. That normally the health minister and the health secretary, and quite often the ambassador in Geneva. Ambassador also sit there. Then if any country got their own health ambassador, they also sit there. So these are the 4 people. But the delegation may have more people that they may not attend the World Health Assembly. There are 3 forums normally. There are Assembly A, Assembly B, and also the parallel and other sessions. So Assembly A is about the thematic discussion. Assembly B is about human resources, financing, budget, and also the auditing. Those issues are discussed in the Assembly B. Physically, there are 3 areas this being taken place. So the official delegation, 4 people may be sitting at the main body, and others they spread out in all other sessions. So the minister or minister designated the delegate. So the minister may write saying that so and so may be representing, but the actual delegation may be, and I mentioned that the United States sent 50 people, China sent 120 people. Many countries, South Africa had a large segment. I didn't manage to get the exact number. So many countries they sent a large number of delegates. So World Health Assembly is assembly of the Ministry of Health and mostly with the ministers of health.
Right. Okay. Great. Thank you.
Thank you very much for your question, Arshu. So any other questions that we have?
Which other country have the capacity to lead the next generation agenda? It's no USA.
So this is one of my slides about power dynamics and changing power dynamics. When you talk about how to influence global health, that is on various levels. It is not you directly influencing the WHO alone. You may influence the global health agenda by setting the intellectual part of it through the research output. Any country can produce research output. And incidentally, I'm the editor-in-chief of Critical Public Health. In a year, I review about more than 1,500 papers. And I can see from which country, who are the researchers, including Australia, what themes they're coming. So that's the one way the academic community can influence major thrust in the areas of that. Because, for example, one of the recent paper from Australia came, the what do you call Uber Eats and how that is influencing on the health and well-being of Australians. I was really fascinated because I'm not disclosing because it's just still not yet published. So that way there are many cutting-edge research can be done. That's one way of influencing. That can be anybody. And the resource implication, you have to remember that OECD countries, they unilaterally cut down for the overseas assistance, including global health. So across the country, not only United States, other countries also cut down their contribution to global health. But interestingly, new players are coming. And I was surprised to see that Mongolia, they contributed $100,000 to WHO, and they publicly announced it. And also across the board, all the countries, they increased their contribution 20%, every country, because WHO is running on the contribution of member countries. And that member countries' contribution is set by a very complicated negotiation. How do you set the agenda, the amount for the membership? So membership, each country they contributed, but Australia also increased Australian contribution. I think Australian ambassadors allocated money is about, I think, 400 million. On the top of it, Australia contributing towards the Global Fund. And also there are other specific programs, and Australia is a major donor for the Pacific country health program. So this is a way. And increasingly, China, they have publicly announced saying that over the next 5 years, they're going to contribute $400 million. But then we have to look at, there are other issues that are coming up. One of the issues which I didn't mention here is about when you talk about NCDs, the session I attended most was back-to-back. I attended the NCD Global Synod, non-communicable disease, and its burden of the non-communicable disease. One of the issues coming up, self-care. Self-care is got a very prominent attention at many of the side events. The self-care could be promoted by any country, mostly for developing countries, and the protocols and all understanding about self-care and also ethical issues. All this has a very huge research is involved. And can we have a diploma in self-care? Can we create an education program in self-care? What is the minimum understanding about self-care? This can be done by any country. So in nutshell, your question, my answer is that there are many countries can impact in many ways. And one way in future, one of the lessons is that don't allow any one single country to influence and impact global health. Don't put your all eggs in one basket. So this is a major lesson from US withdrawal. And it gives new opportunity, new players. We don't know how it's going to go, but there are new opportunity leadership. And many of the countries, developing countries particularly, they can come out with an agenda, national agenda for global health diplomacy. An agenda includes investing in human resources, investing in attending and participating in the World Health Assembly and negotiating for their position, and also production of the material. I mean, with the pharmaceutical material in many countries, has developing countries have also got potential. Even a country like Bangladesh is a major producer of pharmaceutical company. India is a major producer of generic medicine. China is a major producer of raw material for medicine. So all these are the opportunities. How do you gather together? And also you understand that there are, in Australia, got about 17 global health courses in Australia, School of Public Health. So there are human resources are untapped in the global health point of view. So that way, again, that new opportunities are coming up, but people are not prepared to take up this opportunity. That requires more planning, more academic consensus building. Maybe Australia could, you could have a session on how to utilize what are the new opportunities, how to utilize those opportunities, what is the cost of it, and what is the risk of not taking that leadership.
Thank you very much. Yes, please.
I mean, this is a question many people formally ask me, informally ask me, personally ask me, how do you attend the Global Health Assembly? Officially, each country sent a delegation. So you should be part of the official government delegation. So one of the ministers should be sympathetic towards you, put your name. That's one part of it. Being in Australia, you could request the Australian government to include you as a student, or maybe as a, maybe if Australian Public Health Association can put up a delegation saying that we are nominating this based on certain criteria. You set up a criteria, the best MBA student, the best grade, whatever maybe. You set up a criteria and say that Australian Public Health Association is going to nominate 10 students to participate in. This is the second part as part of the official delegation. Then there are side events. Side event is being organized by anybody. So if you are following a certain themes and all those thematic areas, there are global leading players, leading NGOs, leading association, and then you try to get in touch with them and ask them, will you get an invitation for those things? So this is the second part of it. Then there is something called the non-state actors in official relation with the WHO. That is a technical word. Means there are about 200 plus agencies got official recognition or acknowledgement with the WHO. They can send about 6 delegates. So find out who are the agencies in Australia, whether you could be part of that, and you go as an intern. So this is the fourth part of it. But this side event, anybody can attend. But then you should know which side event, how and where it is, and that information is not public quite often. So that you should have you should be networked very well to understand that. And that the key word is that you focus on one thematic area. For example, NCDs, non-communicable disease, that is specialty. Look at who are the major agencies setting the agenda. And in most of this 8,000, I mentioned that 8,000 staff in WHO, most of them, they lead one particular theme. So your area of interest, for example, health diplomacy, there's a focal person in WHO. You should find out the focal person of your area of interest there. Then finally, WHO invite internship for public health. Every year they invite about 40 students. And that is a selection, very competitive process. That's a part of it. And that is already in the webpage. And to get that, you should get a nomination from your country governments. And also maybe the National Public Health Association can nominate. Maybe the school can nominate, saying that you should attend that because of internship. So attend the World Health Assembly. There are various ways to do that, but you do your homework and plan accordingly. And next World Health Assembly, I'll be happy to assist you. If anybody is interested, I can tell you the way, not that I can get an invitation. I can tell you the way. Thank you.
Thank you. Arshu, go ahead with your question.
Yeah, I'm very interested in this. So the science meetings that take place, what effects do they have on, the subject becoming a topic on the agenda of the main forum, if you like, at WHO summit?
Thank you. And I just briefly mentioned in my closing remark, what are the unmet agenda?
Yep.
What are the unmet agenda at the World Health Assembly? And I mentioned that one of the major concern about global health is about health equity. And the health equity has to be implemented at the national level, at the provincial level, at the local level. At the Geneva level, you talk about policy at the global level, but percolating it and filtering down to the grassroots level, that is for the national governments, national institutions, national agencies to do that. But that area, you can see a policy implementation lag. It can be several years. And some people say that what was discussed in Geneva, it takes about 10 years to implement at the local level. Because these are the major issues. For example, take the case of the significant gap in the various culturally and linguistically diverse population in Australia. Their access to resources, access to medicine, there are significant gap in different population group in Australia itself. That bridging the gap is a 10-year behind if you look at the resource allocation and also discussion, research, and actual implementation, even in Australia. And many of the developing countries, priority issues are left out. And I was just discussing with Robert and your colleague. One of the major issues about Sustainable Development Goal as as a major, the global concern. But the global sustainable development goal has to be achieved by 2030, just down the few years more. But we know that sustainable development goal is not going to be achieved, not even half of it. But within sustainable development goal, there are 15 goals and targets 15 targets are directly related with global health. Out of that, again, 50% will not be met. There is no significant discussion about unmet global health agenda or sustainable development goal nowhere in the discussion. So this is, I mean, I was trying to understand what is missing in this World Health Assembly. But earlier also there's a discussion. I looked at historically on a longitudinal analyzed it. The Global Health Agenda, Sustainable Development Goal, health-related targets and indicators were not adequately discussed because of the time constraint. 2030, it has to be met. And we should have a doubled up effort towards implementing that. That effort didn't come from WHO. Maybe WHO is too much concerned about their own survival. I'm sorry to use that word, but that is the reality because WHO is put under so much pressure. So they're struggling for their immediate attention in their own survival. So they lost the global mandate for and advocating for global health advocacy. So this is one of the issue which, as a student, maybe you can take up your research as part of your personal vision about how to be meaningful in the area of public health and global health. So that is, I leave it back to you. But that's what I discussed that, I mentioned that I may have my own bias in the presentation. What are the areas I picked up, what I didn't pick it up, and what WHO's thematic issue didn't pick up. There are many gaps in the addressing the critical issues. So addressing health equity at the local level is still an issue. Thank you.
Thank you very much for your question. Is there anyone else who have a question or something to share? If not, I would like to thank again Dr. Joe for being here to give us this excellent presentation, to learn from someone who has been inside the arena where this global diplomacy happened. For those who have done global health, we have talked about global diplomacy. And for those who are doing this trimester, we are going to cover a little bit more. But I think this has been a great opportunity because we have the reality of what is global diplomacy, not the theory that we usually give in these classes. So thank you very much. And again, a round of applause, please.
Yeah, thank you.
Yeah, hopefully we will have you back, maybe with other themes. I know that you are an expert in different areas of health. So thank you very much. Thank you. Thank you. And thank you everyone for attending. For those who are in 6002, we're going to continue a little bit more because we have to talk about the assessments and that academic staff. Lian, also, you will. Yeah, so the same. Let's have 10 minutes and then we are going to go to with the class. Okay? Thank you very much. Just let me.